Good afternoon. My name is Celeste Tyrell, and I'm GATNA's Director of Online Learning. We're so glad that you could join us today. We'd like to thank Avenir for sponsoring this webinar. Before we get started, I just want to take a moment to review a few of our technical features. We would like for today's webinar to be interactive, so we encourage you to submit your questions to our presenters using the Questions tab on the left-hand side of your screen. Feel free to submit your questions at any time, and our speakers will do their best to address questions verbally at the end of the program. If you'd like to take notes, simply click on the Notes tab on the right-hand side of the screen. Any notes that you take there will be emailed to you automatically at the end of the presentation. If you experience any technical problems during this webinar, please click Request Support in the lower left to receive assistance from our technical experts. On that note, I'll turn the presentation over to Nanette Lavoie-Vaughn, who is a doctor of nursing practice, and she will be facilitating today's webinar.
Good afternoon, everyone, and welcome to our webinar today on neurological behaviors. We have two wonderful speakers with us today, Dr. Brian McGrory, who is an assistant professor at the Duke University School of Medicine and practices at the Duke Neurological Disorders Clinic. And then he will be discussing the background of neurological behaviors as far as their etiology, how they occur in common neurological conditions, and specifically some issues with dementia and non-pharmacological intervention management. And then we also have with us Dr. El Kobahi, who is a pharmacist at Parkland Hospital in Texas, and she will be covering the pharmacological management of neurological behaviors. And so I'd like to now turn it over to Dr. Brian McGrory, who will continue with our first part of the presentation.
Wonderful. Well, thank you so much, Nanette, for that very kind introduction. I really appreciate the opportunity to speak today. This is a topic that I think is extremely important and one that I'm really kind of passionate about, and it's the neurobehavioral manifestations of neurological disease. These are my disclosures. None of them are relevant to the topic today. So, when we talk about neurobehavioral manifestations of neurological disease, it's often good to start by just kind of calling to mind that we're often talking about some of the most difficult and most personal types of, issues that people face with neurological disease. Neurological disease, in my opinion, is the most disabling form of disease by and large, and there's good data to support that. But when we really get down to those neuropsychiatric manifestations of neurological disease really can lead to some of the most difficult kind of personal circumstances that we can think of. And there's many different, artists who try to sort of capture their own personal experience with neuropsychiatric disease. And what's often comes across, in these works is a sense of, losing a sense of self, or a sense that someone's been, fundamentally changed by what they're going through, which really sets this apart from other forms of, even from neurological disease, but disease affecting other organ systems as well. There's many different types of behavioral disturbances that can really manifest from neurological disease. And when kind of thinking through and trying to unpack what are the different behavioral disturbances, we can often talk about four kind of main things: sort of the tempo of the disturbance, the site affected within the neuroaxis, the neurotransmitter system involved, and then patient level differences. And these can sort of, to some extent, help organize our thinking around trying to sort through these different types of behavioral disturbances. I think tempo is probably the most important one. The timing, both in terms of the acuity with which behavioral disturbances start, whether they're persistent or transitory, whether they fluctuate or not, and whether there's any sort of provoking factors that can cause a person to manifest behavioral disturbances. And sort of the classic thing that we often think about when we're talking about the tempo of the behavioral disturbance is this quandary that often comes up as sort of dementia versus delirium. These conditions can certainly coexist, but dementia, as everyone on this call knows, is characterized by a very steady, gradually and slowly progressive decline over a period of weeks, months, and years. By contrast, delirium is something that comes on, rather suddenly by contrast, and instead of being sort of slow and steadily progressive, it tends to sort of fluctuate, and thankfully can actually resolve with the correct treatment. Then we can talk about sort of the site involved, the different lobes of the brain, the frontal, temporal, parietal lobes can each manifest with their own suite of different behavioral manifestations, and that's something I'll turn to specifically just in a couple of minutes. We can talk about the neurotransmitter system involved, which differs based on the underlying condition. We know, and for example, Alzheimer's disease, there's an acetylcholinergic deficit, which we feel manifests in a lot of the long-term cognitive impairment, but also some of the behavioral disturbances that happen in Alzheimer's disease. And then there's a huge number of kind of patient level differences as well. So much depends on a person's background, their baseline, their own circumstances in which they find themselves. And there really is this reciprocal relationship between a person's biology, their psychological manifestations, and their social situation as well. And the so-called biopsychosocial model is particularly important for understanding the behavioral manifestations of neuropsychiatric disease. Let's talk about dementia first. The neurobehavioral manifestations of dementia are very common in all forms of dementia. It's thought that about 80% or more of people with Alzheimer's dementia, for instance, have some form of neurobehavioral manifestation, but this can also be seen in vascular dementia, frontotemporal dementia, and then dementia that occurs secondarily as part of another separate disease process. One thinks of Parkinson's disease and then Huntington's disease as well. There's a lot of crossover in the different manifestations that can happen within these conditions. Depression is very, very common. Anxiety is very, very common. Apathy or sort of loss of volition or interest is very, very common. Disinhibition is seen and can be seen in all types of dementia, perhaps most classically described in frontotemporal dementia, but it can be seen in other forms as well. And then, of course, we all know agitation and aggression can be some of the most challenging features when someone has neuropsychiatric complications of dementia. When we think through how best to treat the neuropsychiatric complications, specifically of dementia, non-pharmacological treatment is preferred, and we've got a large body of experience and observational data that suggests that non-pharmacological treatment is the ideal form of treatment, at least to start with. Pharmacological therapy is obviously crucially important and changes the lives of patients and families with neuropsychiatric complications of dementia, but where at all possible, it's great to start with non-pharmacological treatment first. Why? Well, it's by and large less invasive, and also doesn't carry to the same extent the risks that are associated with any medical therapeutic. There's always going to be risks, and the non-pharmacological treatments we often think about are caregiver and family input. The care of dementia really involves the care of the entire family, and trying to engage and form alliances with the entire care team is extremely important. And we know that this helps with some of the neuropsychiatric complications. And then there's a whole different suite of other non-pharmacological therapies that have been described, which kind of in my mind, I broadly class just when I think through things as sort of interventions that we do, and also preventative care, like preventing things that can actually precipitate neuropsychiatric complications. So in terms of the interventional things, music therapy has been well described, exercise has been well described, redirection, frequent redirection has been well described, just to promote orientation. But perhaps just most importantly is actually good sort of preventative care and thinking through some of those things that can actually cause a behavioral worsening in a person with dementia. And so we think of general medical care being extremely important, frequent primary care checkups, ensuring that a person doesn't have anything going on that's actually triggering or exacerbating the neuropsychiatric complications. And we can think of infection, toxin exposure, electrolyte disturbances, endocrine disturbances, particularly disorders of glucose control or thyroid disease. It's really important that a person with dementia has regular hearing, vision, and dental assessments, because impairments in hearing and vision can themselves precipitate a behavioral worsening in people with dementia. And with regards to dental care, that's important. Because pain can cause a further worsening of behavior in people with dementia, but also dental disease, when it's advanced, can precipitate infection, which itself can make things worse. And that dovetails nicely with pain management. Pain is a well-known precipitant of neuropsychiatric complications, and so trying to find that balance between treating a person's pain versus avoiding the sedating effects of medications, for example, those in the opiate class, which can often be challenging, but at least understanding and addressing and doing what one can to address pain is very, very important. Delirium is one of the most frequent complications of dementia, and especially in the in-hospital setting. And the timing of onset is very useful in terms of distinguishing an acute delirium superimposed on dementia versus the kind of the long-standing disease progression of dementia. And as I discussed earlier on, delirium tends to be a sort of acute or subacute type presentation with a fluctuating course, often associated with a disrupted sleep-wake cycle. And the hallmark is impaired attention. This is sort of the central, the essence of delirium is that there's impaired attention. Whereas in people with dementia, attention, at least in the early stages, typically is normal. And that's probably the main kind of distinguishing feature of the two. Delirium is an extremely important condition in and of itself. Delirium is distressing to patients and their caregivers, but it's also known to be strongly predictive of several adverse events, including mortality, in-hospital mortality, overall mortality, hospital complications, increases length of stay. And there's very good data that suggests that, delirium associated with an index hospitalization is associated with a higher risk of mortality in the case of the paper that I'm displaying now, a year after discharge. And there's also good data that after cardiac surgery, delirium is strongly predictive of negative outcomes independent of other factors. And so when we talk about the non-pharmacological management of delirium, so much of this is actually excellent preventive care, but some of the measures that are preventive care also are useful for treatment. And so I'm going to show two pictures. This is a person in a hospital bed, and what can we kind of see in this picture? Well, the person's, they're lying down, the room is dark, they've got the covers on. There appear to be several lines. The person has a blood pressure cuff on. We can venture that they may have a catheter. They may have at least one IV line. This person is in a situation where they're in a dark, perhaps disorientating, slightly stressful environment, and it's not immediately clear whether it's sort of nighttime or dark time or daytime. Sorry. By contrast, we've got a person here who's he's in a hospital room, but he's sitting out of bed in a chair. He's sitting upright, which is going to reduce his chances of getting aspiration, atelectasis, reduce his chance of getting urinary tract infection by promoting bladder motility. The room is bright. He doesn't appear to have too much in the way of sort of extraneous lines, and it's very clear that it's daytime, and a gentleman in this situation I think is less likely to nod off and have it sleep during the day and be awake all night. And so just the contrast I think between the different modes of treating people in hospital. And so the main thing to both, and again, this is both a treatment, but also a preventative measure for people at risk of this important neuropsychiatric complication, are, to keep during the day, the lights on, and by contrast, the lights off at night, to keep the curtains up, to keep a person out of bed to chair. If it's medically appropriate, ideally we could hold nighttime neurochecks and vital signs, because this will then reduce the risk of a person having a disrupted sleep-wake cycle. To the extent possible, we should try and minimize intravenous lines, urinary catheters, and the use of restraints. Frequent reorientation is important, and then monitoring a person's bowel movements, their urine output, and their pain level to make sure that there's not, these easily treatable but very, very important precipitants of delirium. And of course, we should try, where at all possible, to minimize the use of opiates, benzodiazepines, antihistamines, and other centrally acting medications in general, as these can all promote delirium. So neurobehavioral manifestations of stroke are very, very common. And, when someone has a stroke, oftentimes there's, the most visible symptoms are involvement of a person's motor system, facial droop, arm weakness, leg weakness, difficulty with walking. But there's a whole separate sort of slew of other effects of stroke that are often more subtle and often more hard to detect. And those are disorders of mood, attention, concentration, disorders of emotion, and disrupted sleep, which can happen after a stroke. And one of the challenges that we often face as neurologists is people will say, well, I've made a recovery. I've been discharged from rehabilitation after a stroke. Everyone tells me I look like $1 million, but I've got mood fluctuations. I can't concentrate on things, and my sleep is disrupted. And this is very, very common, and it gets to really the location of the stroke and whether there's either these so-called eloquent lesions within the brain or lesions in the brain that are considered to be non-eloquent locations, such as the non-dominant frontal lobe, where the downstream effects are sort of less common. More rarely, but it can also happen in stroke. People can have frank personality changes, a diagnosable affective disorder, or even psychosis. All of these things are recognized complications of stroke. And so a stroke affects every person differently. It depends on a person's individual baseline and overall health status, but it's also dependent on the quality of the stroke itself. Is it a single infarct, like I'm demonstrating here, which is this a small stroke in the person's left insula, or is it multiple infarcts where you have, as I'm demonstrating here, both strokes in the right and left hemisphere, and then in the front and the back of a person's brain? These, although they're both a form of stroke, would be expected to affect a person very, very differently. And then also whether someone's had a stroke affecting their right or their left hemisphere. So in the majority of people, regardless of your handedness, the dominant hemisphere is the left, and this is where the language centers are housed. And in people, with strokes affecting the left hemisphere, the most obvious and in some ways most distressing effect is that on speech, and you can have expressive and receptive aphasias. By contrast, when people have strokes affecting the right hemisphere, the dominant and oftentimes most disabling feature is visual spatial disturbances and neglect, hemi-neglect of mostly the opposite side of the world. But there's also, and this has been sort of richly described in a paper we published last year in Journal of Neurology, Neurosurgery and Psychiatry, a whole suite of different neuropsychiatric effects that can happen with a non-dominant hemisphere stroke, ranging from difficulty reading facial expression, mania, difficulty perceiving emotion, neglect, of course, but then also psychosis. And these are very richly described, particularly in non-dominant hemisphere strokes. Parkinson's disease is very commonly associated with behavioral changes, and approximately 27% of people with Parkinson's disease meet criteria for dementia, and of the remaining amount, 90% of people meet criteria for mild cognitive impairment. Oftentimes, people with Parkinson's disease exhibit something, it's often a little different from people with other forms of dementia, and that is there's a degree of disinhibition. And one of the classic features of Parkinson's disease is actually impulsivity. We can often see gambling behaviors. We can often see disinhibition in other aspects of a person's personal life as well. And this is you can sometimes see hoarding behavior. And so this is one of the kind of standout features of Parkinson's disease. But of course, one can also see all of the other types of behavioral disturbances that I've listed earlier on with other forms of dementia. And one thing to keep in mind is people with Parkinson's disease are prone to delirium, particularly with exposure to anti-Parkinsonian agents, but also just with general medical precipitants. Traumatic brain injury is the final category that I want to discuss, and it's a very common reason for emergency department visits. There's 2 million ED visits annually for traumatic brain injury, and oftentimes it leads to, perhaps less visible, longer-term complications. It's by contrast to the other disorders, it's more commonly a disorder of the young, and its peaks and incidence from ages 15 to 24. There's a whole range of severity, ranging from concussion, which I never call mild, but it's definitely one kind of range of severity, all the way up to people with very severe, cerebral contusions and polycompartmental hemorrhages and so forth. And so it can lead to psychosis, depression, mania, post-traumatic stress disorder. And one kind of particularly well-described effect of traumatic brain injury is actually frontal lobe disturbance. And the frontal lobes, as we know, are involved in a variety of different aspects of sort of our higher cognition. The dominant frontal lobe is involved in language, but there's also various aspects of thinking, including executive functions, so sequencing, abstraction, organization, planning. A lot of frontal lobes mediate your degree of kind of apathy. And sometimes what can happen after frontal lobe injury is that people can appear apathetic. They can become very concrete in their thinking. They may have personality changes, and they may just overall, have not the same kind of overall kind of degree of executive function as before. And we sometimes see this in people with kind of blunt trauma. And there's this phenomenon of the coup contra coup injury, which is that if you strike the back of your head, what happens is the brain is suspended within cerebrospinal fluid. And oftentimes, despite striking the back of your head, you might then have an injury both to the occipital lobes, but then at the front of the brain as well, at the frontal lobes, as the brain is compressed against the frontal bone. And so this can lead to this classic sort of frontal lobe lesion with difficulties with executive dysfunction and apathy and disinhibition and so forth. And so, these are some of the more common types of behavioral manifestations of neurological disease. And I hope I've just trying to convey the message that there is quite a lot of overlap between different underlying conditions, and that where possible, we at least like to start with non-pharmacological interventions to treat these. So I want to thank you very much for your attention, and I'd certainly welcome any questions.
For those of you who have joined us today, we're going to be taking questions at the end of the presentation. So see, we already have one entered. So if you have any questions throughout the program, please go ahead and enter those in the area for questions, and we'll address them at the end. So now we're going to move forward into pharmacological intervention. So Dr. Bohahi, it's all yours.
Thank you, and thank you for having me. Okay, like it was said before, it is very important to look at the underlying causes that might cause behaviors and see if there's any unmet needs that need to be addressed, especially since these patients have a hard time verbalizing and expressing what they need. And this includes fears, new or returning pain, infection, medication toxicity is a big one, especially towards the end when patients get older. They have just so many medications on their list and a lot of duplications, a lot of interactions. So kind of looking through those, like we said earlier, anticholinergics in the elderly can cause behaviors, and benzos can do that too, as well as sedatives. So looking at that and seeing if there's anything we can do before touching pharmacological treatment is always the way to go. That being said, when we do go into pharmacological treatment, there are quite a few classes that we can look at to help with these behaviors. These aren't all of them, I just listed the main ones, but the trick here is to kind of match the symptoms to the drug. So for psychiatric symptoms, you have depression, antidepressant, psychosis, antipsychotic, insomnia, hypnotic, or melatonin. When it comes to behavioral symptoms, no root cause can be found, and we've used all non-pharm and we're still having issues. You want to utilize the lowest dose possible for the shortest amount of time. And you're going to target symptoms that are interfering with the patient and the caregiver's function, safety, or ability to provide personal care. I do touch on cholinesterase inhibitors right here. It's usually, you see them prescribed first in the setting of dementia. These have not really shown that much of an effect, or efficacy isn't super robust when it comes to behavioral symptoms, but it does benefit cognition and function, and it can have some kind of positive effect on apathy as well. We'll go into one of the biggest ones, antidepressants. Depression is a common symptom associated with neurological disorders, and it's seen quite frequently. Randomized control trials have concluded that these antidepressants are well tolerated, but they still have limited efficacy when it comes to treating behavioral symptoms other than depression. When we take a closer look at these antidepressants, when we're speaking of the elderly, selective serotonin reuptake inhibitors are preferred. They're well tolerated, especially citalopram, escitalopram, and sertraline. There are a few others in that class, and that's fluoxetine, which has a lot of anticholinergic properties, so we don't really touch that, especially in the elderly. Fluoxetine is another one. It has a long half-life, many drug-drug interactions, so not so desirable in the elderly either. What they did find was for citalopram, a recent warning came out saying that you want to keep the max daily dose at 20 milligrams for patients older than 60. And this is because any strength higher had led to, oh, thank you for switching slides, sorry, had led to arrhythmias. which becomes a little bit dangerous there. So you want to make sure to keep the doses very, very low. Some other antidepressants that work are SNRIs, and bupropion are alternatives to SSRIs. The great thing about SNRIs is it's very effective if the patient has concurrent neuropathic pain or fibromyalgia. So you're hitting the depression and you're hitting the pain, which is also another source of behavior. So you get 2 in 1. Bupropion is great. It is activating. It's a little bit stimulating. So it helps with apathy. If patients don't have a lot of energy, it will get them up and going. But it's also terrible for anxiety disorders because it kind of increases their anxiety. In addition to that, one property it does have is it lowers the seizure threshold. So we don't want to use it in patients that have seizure risk, including our post-stroke patients. The TCAs, so the tricyclic antidepressants, the monoamine oxidase inhibitors, both have very high drug-drug interactions. The TCAs are lethal in overdose, whether it be purposeful or accidental. And in this patient population, it is a potential there. Most important thing is the elderly patients should be dosed at half of the normal dose and then increase to a therapeutic dose in about a week. And keep in mind that elderly patients require a longer duration of treatment to achieve adequate response. So you're seeing upwards to 8, 10, 12 weeks before you get the full maximum dose efficacy. And then another group of medications is our anticonvulsants and mood stabilizers you'll commonly see. These I see more used for mania, manic symptoms, but they can be used second or third line for most behavioral disturbances as well. You'll usually see them adjunct. The downside to using most of these, like the carbamazepine, lithium, and valproic acid, is that they do require blood levels and blood concentration to be monitored for efficacy, as well as to prevent toxicity, and that sometimes can be uncomfortable for the patient and kind of a hassle as well. When we look at our anxiolytics, that is something that we'll see quite commonly, as well as anxiety disorders in these group of populations. Benzos, benzodiazepines, lorazepam, Ativan, all of those we usually see quite frequently, but in this case, we want to use it for acute management only. And the 3 that I've always learned in pharmacy school, it spells LOT, L-O-T, is the lorazepam, oxazepam, and temazepam. These are preferred in the elderly because they do not require oxidative metabolism through the liver, and they have no active metabolites, so it won't accumulate in elderly patients, especially if they have liver or renal dysfunction. These can accumulate and cause heavy sedation or cognitive impairment. And that's another thing we look at when it comes to using anxiolytics, and especially benzodiazepines in the elderly, are the side effects. So excessive sedation is one, cognitive impairment is another one. Something that can happen sometimes is paradoxical agitation. And this is where, for some reason, the patients that get these benzodiazepines have an opposite effect. So they're more agitated, they're more nervous, and sometimes just seeing that medication will stop that from happening. And again, this all leads to increased risk of falls, which we don't want to see in this subset of patients. What we do use first line are antidepressants again, and venlafaxine, duloxetine, the SSRIs all have FDA indications for certain types of anxiety. Again, well tolerated and safe. Oftentimes for anxiety, you'll see hydroxyzine, which is an antihistamine. Sometimes you'll see other sedatives, and we discourage this, just again, increased risk of fall, sedation, confusion. And B-Spar is another one that you can kind of keep in your back pocket. The downside to it is that it takes several weeks to see a response, and a lot of these patients kind of need immediate gratification. So what I'll commonly see is you can use benzo very, very short term while you wait for the antidepressant or B-Spar to kick in, and then you'll slowly taper the patient off the anxiolytic, the benzodiazepine, when the antidepressant starts to kick in. One of the biggest ones are antipsychotics. This is kind of a huge area. It is important to note that there are not any FDA-approved medications to treat behaviors and neurological conditions. And only that, the studies have shown that it only yields modest improvements with a host of troublesome side effects. And the biggest concern being, and I'll go over in a second, is increased mortality when used in elderly patients with dementia. But again, antipsychotics are still used in these patients, and sometimes it's their only and last resort. Interesting fact is, prior to antipsychotics, the way they would manage psychosis was either lengthy asylum stays, sedative drugs, and in the 40s and 50s, they utilized something called an insulin coma therapy. So the patients were repeatedly injected with large doses of insulin in order to produce daily comas for several weeks. And the thought was it would jolt them out of their episode of mental illness, which of course doesn't work. But again, these are used very sparingly. You want to reserve them for aggressive, combative, or dangerous behaviors, or for hallucinations and delusions that are dangerous to the patient. I know I had a patient once that was experiencing hallucinations and delusions, but it was in the form of like cutesy little puppies in the corner of the room, and they didn't really bother anyone, so it wasn't touched with antipsychotics there. Here is a big black box warning that comes up with antipsychotic use. It refers to the increased risk of mortality when it's being used in patients, elderly patients with dementia. At first, it was the second generation antipsychotics that got this box warning in 2005. And then in 2008, you'll see a first generation get the same black box warning. It does have a 1.6 to 1.7 fold increased risk of death when you use antipsychotics in this population. And that's because these antipsychotic side effects are associated with some of the second generation antipsychotics that cause weight gain, hyperlipidemia, and diabetes, increased insulin. These are all big risks for CV, cardiovascular complications, which can eventually lead to stroke, myocardial infarction, and death. So it's something you really, really want to keep in mind when weighing harms and benefits in this specific patient population. If you do have to use it, you're going to want to use the lowest effective dose for the shortest amount of time possible. And that's kind of what I go over here, is just, again, the mindset of using it. There's different things you should look into, and to avoid long-term therapy as well. And you want to start one drug at a time, start at a very slow dose. Don't prescribe 2 antipsychotics at once, or have them on both at once as well. Looking at our first generation antipsychotics. So the use of the first generation antipsychotics has really fallen out of favor due to its association with cognitive impairment, delirium, and sedation. These are highly sedating, especially the chlorpromazine, more sedating than Haldol. We usually reserve that for patients that are very, very aggressive, and the side effect of sedation kind of calms them down. It's actually, chlorpromazine was actually developed as an antihistamine drug initially for nausea and allergies. And then it was encouraged to be developed as an antihistamine with effects on CNS, to be used as a pre-anesthetic agent for surgery. Then it was observed that in patients it induced calmness. And so it was used for patients that were exhibiting psychosis or schizophrenia. And that's kind of how it came about. The second generation antipsychotics, on the other hand, were kind of developed to avoid those neurological side effects we discussed. But in lieu of that, it came with the side effects of weight gain, increased levels of glucose, lipids in the blood, and again, risk factors for cardiovascular disease. Another downside to them is that, or upside actually, sorry, is that it did, risperidone was one of those that was found to be very effective in the treatment of agitation, aggression, and wandering in patients with dementia. So it does help. There is some efficacy, and there is some data behind using these in psychosis and dementia. One thing that was great about these is that with our first generation antipsychotics, you see the extrapyramidal symptoms. And these are kind of involuntary movement disorders, really uncomfortable restlessness, contraction, and the patient can't really just sit down. Very uncomfortable for them, and I feel like also people to see that with the second generation antipsychotics, this risk is much less than first generation, especially in quetiapine. So quetiapine is one where you'll see most commonly used in Parkinson's disease patients. because it won't exacerbate their already present movement disorders. One interesting discovery when it comes to Parkinson's will come by at the next slide, but Nudexa, this is kind of a new drug. Nudexa is the first and only FDA-approved medication for pseudobulbar affect. And that is when, I don't know if anyone's seen The Joker, but in the movie, there's a time where he's in the bus and he's something happens that causes him to laugh like uncontrollably. Everyone's kind of staring at him, and then he takes a piece of paper and hands it to the lady in front of him, and it tells him like, forgive me for laughing, I have a disorder. And so pretty sure it was referring to PBA, but it's where you have involuntary, sudden, frequent episodes of laughing and crying that don't really match up to the situation. So it doesn't make sense that they'd be crying or laughing and they just can't control it. So this is when Nudexa came out. It is a combination product. It's dextromethorphan, which is your over-the-counter cough syrup, and then quinidine, which is an antiarrhythmic drug for cardiac patients. When it first came out, it was used a lot in nursing homes. And I know when I worked in hospice, they were kind of using it quite frequently, not just for PBA, but I saw a lot of it being used to reduce agitation and aggression in dementia. And there are mixed results. They have done a study. It's still showing mixed results, but it does show that it may provide some benefit in those patients. When it comes to the cost, they're expensive. I remember we tried to combine it ourselves, but the thing is quinidine is, I think, at 10 milligrams. And the generic quinidine that's available that's already been used is at 200 milligrams. So you don't want to mix those two at all. But the interesting thing about quinidine is it's actually just being used to increase the amount of dextromethorphan reaching the brain. And that's its sole purpose there. The next kind of new medication is Nuplazid. This one is very interesting. It's a special kind of antipsychotic. It doesn't work on the dopamine receptors like all the other antipsychotics do. It works on serotonin only. And what they found is not only did it improve patients with Parkinson's, their hallucinations and delusions and psychosis, but it didn't worsen their motor symptoms, which, as we can see, the second antipsychotics have the ability to do that. Currently, there is a randomized control trial being evaluated for patients with dementia-related psychosis. Sorry about the slides. This is the Nuplazid. So the randomized control trial evaluated patients with dementia-related psychosis, and they actually had to stop the trial early because of how much benefits they saw. So it might come out soon. The only FDA-approved indication right now is Parkinson's disease psychosis, but we might be seeing it more and more used for behavioral and psychotic symptoms of dementia. And lastly, what is very, very important to all the medications mentioned before is making sure to take the time to periodically look at the patient's medications and really become an advocate for removing an agent that has no obvious benefit. Oftentimes what we'll see is some medications won't have benefits in patients, and instead of replacing it, we just add it and we add more and we add more. And so when you see something has no obvious benefit, is causing side effects, or the behaviors have gone away completely, it's a good time to decrease the dose or trial the medication discontinuation and see if that will make a difference. None of these should really be continued indefinitely. So withdrawal should be made at regular intervals. Of course, you want to wean it off very, very gradually. And the American Psych Association actually recommends that attempt to taper and withdraw antipsychotics be made within 4 months of initiation in patients who have responded to therapy. And so that becomes very important for these patients. All the time towards the end of the disease process, these behaviors are typically gone. And is another reason to advocate for dose decrease or discontinuation. Long-term treatment just ends in many, many complications. And that is all I had.
Okay.
Okay. And
Thank you very much. We do have some questions in the chat. So we'll start with the first question that came in. This person would like to know if the CAM scoring tool is useful in long-term care. It's used a lot in inpatient, but would it be something that would be useful to use in long-term care patients that may be having delirium?
Yeah, I think that's a really good question. And so, for the audience, the CAM score is a confusion assessment method, and it's essentially a screening tool for delirium. And it touches on some of the things that I mentioned earlier on with talk about, tempo, sort of fluctuation, inattention, disorders of sleep. And there's a list of 9 or 10 kind of questions to go through just to assess whether a person is at risk of delirium. Could it be used in a long-term care facility? Yeah, I mean, I don't see why not. I mean, the most common venue for using this is kind of the intensive care unit. We also use it, and there's actually a modification specifically for the intensive care unit, but you do use it a lot in the inpatient setting. But I think any venue in which there's a suspicion for delirium, particularly hypoactive delirium, which can often be very kind of hard to spot. Yeah, I think the CAM score would be a great tool to use. And I don't see why you would not want to use it in any kind of long-term care facility. Yeah.
Okay, thank you, Dr. McCrory.
Thank you.
We have a question about a situation that occurred with this person who works in long-term care. Their facility was cited for having a resident on 20 milligrams of escitalopram as it being too high of a dose. Was this something unusual, or is this something okay to use in long-term care, or maybe at a lower dose?
Yeah, and escitalopram is a great medication too. They did find that it had the same warning as citalopram, with the dose being too high for cardiac patients. And then it does get you to think, is it still going to be an adequate dose for anxiety, depression as well? And I think the main, I see it at 10 milligrams as well, and I see it at 20. I think if you were to increase it to that high dose, if you can show that the patient is at increased risk, it would maybe serve its purpose a little bit better, because I get that, and I think titrating really, really slowly would be helpful too. And once you get to that high dose, making sure there are no complications. Again, there's other medications that could be helpful too, sertraline being one of them. Something else that's fairly overlooked with antidepressants is their other advantageous benefits, like trazodone, mirtazapine, great for sleep impairment as well as depression. Mirtazapine can help with weight gain as well. That it does make it difficult when you can't increase the dose high enough to help with anxiety and depression. But I think there should be ways around it, honestly. I have seen patients be on higher doses. As long as it's physician approved and they're monitored appropriately, it should be okay, I would think.
Okay, our next question is about buspirone. This person says they haven't seen it used that much in older patients and in long-term care. Is it a medication that can be used PRN?
I have actually seen it not be recommended to use PRN, that it would have to be used consistently. And same with the antidepressants. I've seen some be, I've seen Lexapro be given PRN, but I think it has to be consistently given in order to be completely effective. I don't see buspirone used that often either. And it's a great drug too. It doesn't impair memory. It doesn't impair cognitive performance or driving. It doesn't make you addicted like benzos might. Some patients might become a little dizzy or lightheaded. I think it's that it takes a while to become effective. A lot of patients don't have that kind of time or don't want to wait that long. And I also think a lot of the antidepressants have kind of replaced buspirone in terms of hitting multiple symptoms at once instead of just one, too. And I don't know, Dr. McCrory, if you have any insight into that.
No, I've never seen it used on a PRN basis for any indication.
Yeah.
So yeah, I honestly I can't say too much more about that because I've only ever seen people on sort of scheduled buspirone. Yeah.
Yeah. Okay.
All right. The next question, and one I'm very familiar with, is how can we work with staff in long-term care facilities to decrease their dependence on requesting benzodiazepines to control behavior in dementia patients?
Yeah, I think it's a very, very good question, and this is a really important question that we face, quite a lot. I think there's probably two elements to this. I think the first is trying to prevent, the development of agitation in the first place, because oftentimes, this call will come in at, 3 o'clock in the morning, a person's got dementia, they're extremely agitated, they're disrupting their roommates, they're placing strain on staff who are having to devote all their time to them, and they're themselves distressed as well, perhaps most importantly. And so, oftentimes by that stage, it's very, very challenging. So let's just talk first of all about like the preventative measures. So I think there's lots of things we can do to reduce the risk of agitation happening in the first place. And much of it is some of the conservative measures that I discussed earlier on, such as, controlling pain, ensuring a person's got good, vision, that their hearing aids are in, that, they've got a regular sleep-wake cycle, that they're not being disturbed at night, that they're not on any medications that are going to precipitate delirium. And things that we can do, and I don't want to stray too much into Dr. Gobai's kind of realm here, but, if a person's got a pattern of repeatedly needing, for example, benzos, oftentimes putting them on a standing atypical antipsychotic at a really, really low dose at nighttime can be very helpful in reducing the chances of that happening. If someone is in a situation where, they're acute severe agitation, they're distressed and they're posing a threat to themselves and others, and they do need, an intervention. So like the gold standard in that situation is a one-on-one sitter. So the answer, the ultimate ideal scenario would be that a person who is, about to require a benzo is instead kept with a one-on-one sitter who could supervise them and provide frequent redirection. If that's not possible, then, there's alternatives. And sometimes what those in psychiatry will recommend is to use an ultra low dose of a benzodiazepine accompanied by an ultra low dose of haloperidol. And it's felt that like the sum of, the effect of those together is sort of greater than the sum of their individual parts. So that doesn't, decrease the use of benzos, but it may decrease the dose. And then there's some other options in terms of using, for example, atypical antipsychotics as well, which is felt to cause less respiratory depression and so forth. But I think the overall kind of message is that once you get into a point where, for example, a call is being placed to prescribe benzodiazepines, oftentimes that it's perhaps a little bit too late at that stage. And in the setting, unless you have a one-on-one dedicated sitter ready to be with that person, then you're forced to make kind of a difficult kind of trade-off between the benefits and risks of these medications. Yeah.
Mhm.
Did you have anything else to add, Al?
Oh, no, I love that. I completely agree with everything you said too.
Okay. We had a person who asked a specific question. They wanted to know about information about a person's handwriting changing from normal to micro. Is that something that's seen as a neurological behavior? And any explanation of someone saying potato chip when they meant to say paperclip?
Yeah, absolutely. Those are two really interesting questions. And so a person developing, micro, smaller handwriting. So, that's a kind of a well-known kind of neurological condition. Well, condition is not the right word. I guess it's a neurological sign called micrographia. And that's most commonly described actually in people in Parkinson's disease, that a person will develop really, really small handwriting. And it's felt to relate to a lot of the difficulty with sort of very, very fine motor control of the type that you require for handwriting. And it's considered one of the hallmark features of Parkinson's disease. And there's been, sort of very famous kind of case reports published where they'll take a person's handwriting, a person with a diagnosis of Parkinson's disease, and they'll show handwriting samples, once a year for, every year since the diagnosis. And you can often see this transition as a person's handwriting gets smaller and smaller. And then also, sometimes you can actually see within the same sentence a person's writing, you can see that the handwriting starts off normal or close to normal size and then becomes smaller as the sentence progresses. And that's another kind of way of kind of defining micrography, and you often see that in people with Parkinson's disease. It can be seen in other conditions as well. It can be seen in the Parkinson's plus syndromes. It can be seen in other extrapyramidal disorders such as Wilson's disease. It can be seen sometimes in upper brainstem lesions. So it's not exclusively restricted to Parkinson's disease, but that's the kind of most well-known venue in which it's seen. So the second question was about it looks like it's actually gone now, but it was about word substitution, calling something a potato chip instead of a paper clip. And that's an example of a what's called a phonemic paraphasia. And so paraphasias are where you use the wrong word to describe something. And then there's semantic paraphasias, which is where you kind of use the wrong word, but it's kind of roughly similar, or it's the same kind of form of words. So maybe instead of saying daughter, you say son, or instead of saying car, you say truck. That's what's called a semantic paraphasia. And then there's phonemic paraphasia, which is where you say the wrong word, but the word sounds somewhat like the original one, or it may have the same stem as the word the person was trying to say. So you might say, potato chip instead of paper clip, or you might say, far instead of car, or you might say, teak instead of speak. There's just lots of different ways, but it just basically sounds kind of the same. And it's what's called a phonemic paraphasia, typically seen with receptive aphasias. So aphasias in, arising from the temporal or parietal lobe. And it can see in any disease setting where you can get a receptive type aphasia. It can be seen in dementia as one component of dementia. It can be seen if a person has a stroke causing an aphasia. So there's lots of different venues. And I don't know kind of what the particular patient that you're talking about, what the time course of those changes were, but that's a nice example of a phonemic paraphasia.
And then we have someone who wants advice about a patient that they're treating who has Alzheimer's disease and has been grinding their teeth and is currently on Haldol 1 milligram 3 times a day and is now having new onsets of aggression and pacing. And they're wondering, should they just increase the Haldol dose or should they change to a different medication?
I'm not sure if the grinding of teeth is due to just frustration or agitation or stress, or what's causing it. Sometimes you'll see patients will react to an antipsychotic differently than to another one. It doesn't sound like it's tardive dyskinesia where they're making facial grimaces or any type of side effects like that. It could be caused by the Haldol if it started as soon as the Haldol started too. If you wanted to change it to something like a second generation antipsychotic where movement disorders aren't really something to be worried about, it might help to start on a low dose of quetiapine and see if that works for the patient. The agitation, and I guess with Haldol, if increasing it might cause a little bit more sedation, which causes a calming and mood stabilizing effect anyway. If you notice that it was benefiting the patient initially before these new behaviors showed up, it might be something that you could increase. If it seems like these behaviors occurred with the initiation of Haldol, I would definitely consider either decreasing the dose a little bit or switching to an alternative antipsychotic agent. That would be my input. Doc, what do you think? What would you say?
Yeah, I would agree with that completely. And teeth grinding, like I'm not super familiar with that this could be just my own, not knowing it, but I'm not super familiar with that as a side effect of any kind of particular medication. But I mean, the risk there is that you start getting like temporomandibular joint dysfunction and headaches and so forth. And so oftentimes like a bite block or like an occlusal splint can be useful to reduce the complications from that, at least while at nighttime, at least while we're figuring out what's going on with the medications. Yeah.
All right, we have one final question. What about the use of Depakote for dementia and agitation? This person is seeing it ordered frequently and wants to know you all's opinion on that.
I see it ordered a lot too, especially as adjunct to an antipsychotic agent. I know in some early reports, Depakote showed to improve aggressive behavior, but as more and more studies came out, it showed that they weren't super effective in the symptoms of dementia. It was mainly patient cases, and for a lot of my patients, I have seen that work really well. It comes in the various different forms as well as a liquid and tablet, and so that helps too. But I know, I believe most of the studies show that it isn't super effective. I'm not sure if that's what everyone else is saying too.
All right, well, we are down to 4 minutes remaining, and it looks like we've covered all of the questions. So I want to thank everyone for their participation today.
Thank you so much for having us. Appreciate it.
Yes, thank you. I appreciate it.
Thank you, everyone, for being here today. And we thank our speakers. I know that if we were all together, you'd be hearing a round of applause right now. We encourage everyone to complete the evaluation if it is a non-NCPD evaluation, but we still welcome your feedback. And if you have questions, just reach out to the Gatineau National Office. Have a great afternoon.